I'm going to try and keep the technicalities and the economic speech and so on to an absolute minimum. If people find themselves at a loss at any point, please point up and I'll just go over it again. Questions, I think, otherwise in the end. This is very much the work of a whole group of people. I'll introduce them in the end, but I'm claiming ownership of it, at least for tonight. I'll quickly introduce you to the concept of why do we need to care about cost in the first place, and tell you how we were able to use size-specific cost to model the ART budget for the entire country. Then I'll introduce you to my model and tell you the results. It's actually only two types of results. It's very quick: the total number of patients and the total cost over the next 7 years of the ART program. And then finally, the big question, can we afford it? Basically, what is a cost analysis? Well, we all know it. It's a technique used to estimate the cost of a past or a future action. And Green said it quite well, I think, when in 1992, when he said, in order to make informed planning choices between alternative and competing demands on scarce resources, it is imperative that planners are aware of the resources and costs of each alternative. He was talking about healthcare interventions and the decisions faced by ministers of health or treasuries around the world, but it's obviously the same across all government departments. So what we take from this is costing is often used to look at potential affordability and sustainability differences in introducing or expanding programs under two conditions, and these are important. A, we never have as much money as we want to. If we had, there wouldn't be any economists. B, programs are substitutable, and that means you can always do one or the other. They don't all have to be done at the same time. Some of them do. You can't, let's say, have an working pediatric ART program without a PMTCT program, or you can't have an ART treatment program without testing, but most of them are actually extremely replaceable. You can do one or the other, and you have to make a choice. So it's always about helping people making choices, giving them data to make rational choices. Why is it important? Well, we use it to improve efficiency, in this case economic efficiency. There's a whole lot of other efficiencies out there. We try to either gain maximum benefits from a given level of resources, or we try to minimize the cost to achieve a desired level of benefit. So one of them is always constant. We use it to plan new interventions, and that could be both to provide an overview of resources needed to set up or run a project or intervention anew, or to inform decisions on how to expand and replicate an already existing program, or to assess the financial sustainability. So looking into the future and seeing how much longer can we keep doing this. And the latter, I think, is very much what we are trying to do or find out about the ART program in this country right now. So in summary, cost analysis can be used to find ways to make existing interventions cheaper, to cover more patients, and to argue, and that is important, for more spending. In other words, we talk about a pie and multiple ways of cutting it. We also talk about making the pie bigger, and this is something that is very central, at least to my understanding as a health economist. I'm still a physician first and foremost. So it's not only about how should we spend our money, the given amount that we got, how should we best put our budget into interventions that save the most lives or have the biggest quality of life outcomes, but also how do we argue for actually putting more money into health. And even if that is your main aim, you will still need to tell people exactly how much bigger does that pie need to be. You always have to have data, and as almost always in life, I think, when you have more data, more evidence, the thing actually becomes a lot better argument. The pie still needs to be sliced, but it can be made much bigger. The first kind of take-home thing, cost is never the first, but almost always, and you will know this from your own experience, almost always the second consideration in healthcare decision-making. So it should not ever be the first thing. We are not here to save money. We are here to obviously treat the sick, and the sickest first, etc. But then when you have a new intervention, or when you want to expand your intervention, or even if you yourself make decisions about where to put your time, if you want to open another clinic or go somewhere else and volunteer, you're already talking about cost. So as soon as you have something that works, you will have to make the point that it's worthwhile doing for the government, or even for yourself, or for your hospital director or someone. So it's unfortunately, we could say, it's always the second thing. It's always the next thing that stands between the idea and the implementation. this leads us directly to the background to this talk, the situation 2008-9. I'm talking in financial years here. I hope you'll forgive me, but this is kind of the way we're thinking. Pretty much at the end of the financial year 2008-9, South Africa, we know, had the largest ART program in the world. These are the numbers that are the last kind of official numbers that went out, November 2009, the UN gas report. We don't really know how many there are, but we're pretty safe in assuming it's somewhere between 900,000 and 1 million right now. Initiation rates of above 300,000 patients per year over the last 2 years had put a lot of pressure on funding and capacity. And we know that that lead to stockouts widespread and to a moratorium in the Free State province. Just to give you an idea, the 300,000 patients, think of the ranking of the national ART programs worldwide. We are essentially we are the biggest. We are putting the third biggest program, Kenya, onto our program every single year. At the same time, there were discussions starting within the Department of Health about changes to the guidelines, which had a lot to do with the preparations for the new WHO guidelines, which finally came out in December last year, about increased eligibility in better drugs, especially replacing stavudine in first-line ART. But also, that was more a local discussion about changes to drug procurement away from the focus on national on national ART procurement and production, and also changes to staffing level and tasks, so the task shifting debate. All of which would have a lot of implications for cost on top of the already strained system. We were actually it wasn't in April, it was pretty much in March, so even before the change of administration, we were approached as HERO to be part of a costing task team that the NUH convened in order to find a solution to all these questions. And we were tasked to come up with a new model. There have been models like this before, but to pretty much tailor-make a new model to answer all these questions. Mostly to calculate the relative costs of the changes, or the proposed changes to the South African ART guidelines, and then based on these, calculate the resources required for the national ART program going out for 7 years. They only asked us for 6 years, but we gave them 7 because we could do it. They asked us to do it for both government and donors, but somehow we dropped the donors quite a bit. And that is because most of the local program, big as it is locally funded. We got some 83% domestic funding, which is, again, unparalleled in the world. And it was difficult for us to actually say how much the donors were contributing and expected to be contributing in the future. Okay, so the scenarios we looked at were 3. The old South African guidelines that all of us are aware of, and I don't need to go through again, the new South African guidelines, and then the full WHO guidelines. And you can already see, and you obviously know the new South African guidelines, there's a difference between the two. So the new South African guidelines talk about raising eligibility in adults to 350, but only for the TB, HIV co-infected. So that means people with active TB co-infection or pregnant patients. And for children to introduce early pediatric treatment, which means treating kids as soon as they are PCR positive, which means in infancy if possible, so in the first weeks of life, if that can be done optimally. The regimens would see the replacement of stavudine by tenofovir for adults in the first-line regimen for all new initiates, on top of the tenofovir that's already being replaced for people having high stavudine toxicity. And then new second-line regimens, take a short look at them if you haven't seen the guidelines yet, because they are different from what we had before as well. The DDI gets replaced by 3TC in both instances. For kids, it would be replacing in the first-line regimen stavudine with abacavir. The full WHO guidelines are basically the same, apart from the fact that adults all go on treatment at CD4 count below 350. Otherwise, they're the same. Okay, so these are the things we are going to discuss, the implications of. We also looked at 2 additional conditions. The first one is looking at the cost impact of a new drug purchasing system. And this caused a lot of interest when I talked about this in Vienna, because this is something that no one else has kind of tried to do before. You might be aware of discussions around reference lists, which is basically a list that the government gives out of prices for drugs that it would like to see tendering companies kind of match. So it's not really a it's not a kind of legal mechanism that is okay, I'm a little bit out of my depth, but it's so you don't have to match them, but if you could, that would be nice. If you're far off, there's no point putting in your tender. Any more detail on this, you'll better talk to the Department of Health directly, because I wasn't really involved in this reference list. But how it works is that they looked at the cheapest prices given out by 3 international organizations or negotiated and maintained by them: the Clinton Foundation, the Global Price Reporting Mechanism that's maintained by the WHO, and the Supply Chain Management System that's run by PEPFAR, the prices that they got, and compared it to the last South African government tender, and whichever was the cheapest for every single antiretroviral, they put that price went into the reference list. So this is basically the internationally cheapest available antiretroviral drug prices. The second thing we looked at is task shifting, and that is introducing ARV initiation and management by nurses under physician supervision, and ARV dispensing by pharmacy assistants under pharmacist supervision. And you're probably all aware of this. The reason why they asked Hero to do it is because we've been for at least 5 years now collecting site-specific costs in a number of clinics, both in South Africa and in Zambia, and also in Kenya, looking at differences in the cost of providing ART across models of care, different models of care in one country, but also across different countries. This is how the cost for this model came to be. We looked at the public sector clinic, Tembaleto Clinic at Helen Joseph Hospital. The clinic started in April 2004. It is probably the biggest clinic in the country, if not in the world at the moment. We have some 14,000 patients actively accessing care there. It provides standard care therapy. Obviously, it's changed now. The data collection for the cost analysis was between 2007 and 2009. This is how it worked. We did a bottom-up cost analysis, which basically means going into the site, pulling 200 patient files and going through them and looking at every single drug and lab test and whatever they used, and then multiplying that by the unit cost. From the provider perspective, which means basically we included everything that was in the hospital files. We looked at fixed and variable costs, and that included drugs, ARVs and non-ARV drugs, diagnostics, staff and overheads, basically including the whole cost of running your ART clinic. But that also meant we stopped at outpatient cost and didn't include inpatient cost. And for the budgeting, that's exactly what they wanted, because the inpatient cost is born from the hospital budget and is of no interest to the ART budget as such. You could say that's silly, but in this case, it's just providing ARVs. We included, for the purpose of the model, the cost of VCT and pre-ART care for eligible patients. And we also included the ARV cost for children, or the same cost for children. We did, at the time of this model, not have a bottom-up cost analysis in a pediatric ART clinic, so we just pretended. We assumed it was the same cost, but we adjusted the ARV cost, obviously, for the different drugs and adjusted by age and weight bands. All costs were updated to 2009, and that means that the ARV cost, they're actually further updated to the latest tender prices from February 2010, and the staff costs include the OSD from last year. The new regimens that we included, so the tenofovir and AZT and the abacavir, there we just replaced the stavudine cost by the cost of the other drug, and again using 2010 tender prices for that, and also included a couple more lab tests like creatinine for tenofovir, etc. Okay, so this is what came out of it. This is pretty much the cost of treating an adult with first-line ART in South Africa, the whole provision, all the staff and everything else, not just the drugs, even though the drugs are the biggest component of that. So an established patient will cost you 5,000 Rand per year on first-line adult. For the first half year, it's more expensive than any other half year thereafter. If you fail, you're a bit more expensive. There's 2 more viral loads in there. And second line is double as expensive as the first line. All of this has been published, so if you want to know the details and the kind of breakdowns and so on, please feel free to come talk to me or, basically look it up. For the new guidelines and the full WHO guideline scenarios, we looked at the cost of tenofovir and AZT regimens with their corresponding second-line regimens. As you can see, they're just a bit more expensive in any case, but it's not huge. It's not kind of doubling it also. And the second line is actually less expensive because there we go down to AZT, so it's less expensive than, and also because of the replacement of DDI by 3TC, it's actually quite a lot less expensive. Okay, for kids, as these things go, it's much more complicated. There's actually 2 of these columns in each of them that I have omitted. But what you can take home from here, it's except for infants, it's more expensive to treat kids than adults because of lopinavir, ritonavir in most cases. And again, when we replace D40 by abacavir, it becomes more expensive. Okay, so far on the inputs. Now the model. This is how it looks like. It's an Excel model, which was part of the whole brief. So in order for the DOH to use it themselves, but also for other people. So if you want a copy, please let me know. This is the first page, the assumptions page, and as you can see, there's lots and lots of boxes, and I won't go through them in detail, that you can choose your regimens from, your kind of scale-up dynamics, your currency, basically, you can put in or take out the OSD and so on. So whatever I said, all of these things are optional things, and you can run it with or without. The white thing is our model, the NACM. We start with numbers in need of AAT, the IN here, which is an output of the ESSA model, the Actuarial Society of South Africa AIDS model from 2003. They also tell us how many people they think will be covered with AAT. There the assumption is that we cover 80% as in the NSP going onward from this year. Then we look at people in first-line AAT. They have a certain rate of treatment failure, go into treatment failure, then get covered with second-line AAT, go into the second-line AAT kind of box. From each of those, they can either die, sorry, that's a bit illegible, due to, according to mortality rates, or get lost to follow-up and go into no care. We did all of this for 5 different age groups, 4 different kids age groups, and then above 13 is treated as adults. And it's differentiated by newly initiated patients, so the first 6 months versus established months. Okay, in each of those green boxes, this happens, and that is that everyone gets then kind of, once they're on first or second line AAT, gets redistributed between health states, which are defined by CD4 cell counts or percentages for kids. I only have the adults here because it's already too much information, I think. So why they are important is that all mortality and loss, but also your likelihood of then going to a higher or lower CD4 count depends on your CD4 count. And in this case also, for adult on first line treatment, it also depends on your time on treatment. This is the first time that we've been able to do this at this level of detail. It adds to the precision in your estimate, including to your precision in your cost estimate, which is why we did it. Basically, the model calculates total cost as a product of numbers in need times coverage times per patient cost. And the numbers in need and coverage come from the ESSA model, and all the other cohort parameters, so death, loss to follow-up, etc., come from 2 big cohorts. That's the Tembaletto Clinic, again, the same that we use for the costing, and the Harriet Chasey Children's Clinic at Barra. Together, they contributed 13,000 patients with observations, which has not been done before. And this is the reason why we did it. It's a huge matrix. We have lots of them in the model. It's mostly here to impress you, I hope, a bit, that we got... So basically, all the other models before have one line for all of AAT, first line AAT, but we have it kind of broken down by 6 months on AAT, which, as I said, adds to the precision. And what it does is, basically, here is your kind of population, your entire model population distributed into CD4 cell counts. As you can see at the beginning of the program, everyone was in the yellow or red line, so in the kind of below 50, below 200 categories. And now we can safely assume that more than 50% are in the higher CD4 counts. Oh, sorry, now it's here, so we are about getting there. But at the end of our projection by 2016-17, everyone will have been redistributed, and that is despite of new people coming into the model or into the program at lower CD4 counts all the time. So far, there's lots of assumptions in the model. The main assumptions is we think that the initiation rate of the coverage of newly eligible patients is 80%, because that's what the NSP says in patients below 200, but we think it's only a third of that in patients between 200 and 350. We don't really know. We haven't run this in the public sector. We don't have enough data. We have data from the private sector in South Africa from 848s, and they seem to suggest that people are less likely to go ahead and initiate when they are less sick, basically. The other thing is our cost does not differ by CD4 count, but only by type of treatment regimen and age. Regimens do not differ in their mortality and loss rates, and task shifting, again, has the same effectiveness as the standard care. The only thing that gets affected by it is cost. This is now the first results slide. These are the total numbers of patients that will be initiated over the next 7 years under the old guidelines, new guidelines, and full WHO guideline scenarios, respectively. We think we'll be putting, in actually each of those scenarios, about 3 million patients on treatment in the next 3 years. The new guidelines, so adding the eligibility at 350 for the TB co-infected and the pregnant patients, will add exactly 14% to that. That's not a lot. I was quite surprised. If we implement the full WHO guidelines, so 350 for every adult, we add another 23% to, those 2.7. So in other words, as you can see here already, we're not doubling the program or anything like that, which is mostly driven by this assumption that only 30% of those who should will come forward for initiation between 200 and 350, which I still think is quite an realistic assumption. In terms of the patients on ART by year, we are assuming that whatever we do by the end of this year, we'll have 1 million patients on treatment. If we introduce, going ahead with the new guidelines, which are already introduced, we'll add 6% into implementing the full WHO guidelines, 24%. But much more importantly is that between this year and 2016-17, the growth in the program will be 130%. It will be 148% under the new guidelines, 133% under the full WHO guidelines. So in order to, I have another slide on this to make it a little bit more clear what I'm talking about. So this is the growth in number of patients under each of those scenarios. So the blue is for the old, the red for the new, and the greenish thing that looks yellow is for the full WHO guidelines. And here we started the end of 2009, so around about now, the financial year. So, in April this year, at the same number. This is the amount of patients, the amount of growth that you will see would have seen under the old guidelines. It more than triples the number that we see now. We go from just about 1 million up to more than 3. So if we add the people who will be additionally initiated under the new guidelines, that adds in exactly 14% over here at the margin. If we implement the full WHO guidelines, it adds another 10%. Which leads me to my second important take-home thing. The growth in number of patients on ART over time as a result of prevalence, so simple need, is higher than the growth in number of patients as a result of increase in eligibility. So going back to that slide, we shouldn't be wasting much time debating this margin here, another 14 or 10%. We are putting all these people on treatment anyway. We've already, we're doing this. It's in the NSP. There's no stepping back, and there's no discussion about stepping back from that. So this is already going to break the bank, if at all. But then debating those little additions isn't. Now, this is a little bit difficult, and I'll actually jump in. This is the regimen distribution, or distribution into regimens under the new guidelines. This is mostly interesting for pharmaceutical companies and people trying to plan quantities ahead and so on. I just wanted to say we got it. Okay, this is now the results in terms of total cost. On the left here, you see the full cost. And bear with me for a moment and concentrate on those only. This year, we will, even if we only implement the old guidelines, which we already stepped ahead from, we will be spending 7.8 billion rand on the ART program. And that is not just the drugs, that is treating patients, so paying for everything they need in the clinic. This will go up to 19 billion over the next 7 years, and we'll be spending over the next 7 years a total of 95 billion. Under the new guidelines, this goes up in total by 17% to 110 billion. The full WHO guidelines would cost us 125 billion, which would be an increase on the old guidelines of 32%. So in other words, the total cost of the program increases by 17% and 32% respectively for the new guidelines and the WHO guidelines scenarios. And that is as a result of both higher numbers of patients coming forward, but also higher drug costs for the tenofovir-containing regimens. Now there's a lot of things we can do to get that down, and that is actually the thrust of our work and of this talk. If we introduce task shifting and the reference list for drug prices, then we can shave off a third of each of those costs here. And that means that for the new guidelines, we can go to down to 70 billion. For the full WHO guidelines, we can go down to 80 billion rand, which, as you will see, is less than the 95 billion we would have spent on doing nothing, changing nothing, and just continuing with the old guidelines. And that is quite important. So in other words, costs will go up, they will continue to go up, and we are spending a lot of money, which is again mostly because of prevalence going up and need just going up, but there are ways of reducing that increase in a way. So if the new drug purchasing mechanisms or the reference list and task shifting are implemented, then the new guidelines and the full WHO guidelines will cost less than the old guidelines. So in summary, we can see this, the yellow bar in the middle is again the total number of patients under each of those scenarios. And we see it going up, but there's not too much of an increase between those scenarios. The green bar is the total cost. And you can see it goes up just a little bit more than total patient numbers, and that is mostly because we now have tenofovir that is more expensive. But if you look at the red bar, that's the total cost of the under the reduced cost, so implementing the reference list and the task shifting. And that is well below each of the, below the cost of the old guidelines at full cost. So we would be saving 33% if we still continued with the old guidelines, 25% on the new guidelines, and 16% on the full WHO guidelines if we implement those two measurements. There's a couple of limitations, as always, as in any study. We have this assumption that the rate of initiation between 200 and 350, so those additional people coming through under the new guidelines, is 30% of that below 200, which might be an over and on underestimation. We don't really know. We will have to see how it plays out in the next years. Cost in our, as I mentioned, in our model does not differ between CD4 cell counts, and inpatient cost is excluded. This, we don't really, when we look at our data, we don't see much of a difference between CD4 cell counts in what patients cost, but we don't have a big enough sample to really say much about that. Effectiveness is assumed to be the same across all regimens, and importantly, it's also assumed to be the same in the task shifting scenario. Now, obviously, if one of the ideas of task shifting is to also enable primary healthcare centers to implement care, and that is much closer to patients, and travel cost and time is one of the main reasons why people leave the program, then we could argue that there will be more patients in the program, less loss to follow up as a result of task shifting. But again, we don't know. We know from a trial run here in Johannesburg that nurses will do as good a job as doctors in administering it under trial conditions. We have no idea in routine care. Lastly, for the test and treat people in the audience, we did not include any impact on transmission, and that's because we only model over 7 years. You could argue that at population level coverage, as we are modeling, 80%, you will have an impact on transmission. But because we stop after 7 years, any impact on incidence will not bear out in the numbers coming through needing ART. It's just a different timescale. Conclusions, can we afford it? We did one more thing. You can always do a budget analysis, a cost analysis, but it doesn't really tell you much. It looks like a lot of money, and I know everyone in this room is kind of astounded, but you don't know what it means unless you look at the size of the pie and compare it with the entire budget that's available. And that's what we did. We compared it with the public health service budget that has been detailed in the budget review 2010. So this is data from February this year. And it went into the budget speech, basically. So if we look at the percentage that each of those scenarios would cost at full cost, we can see that the old guidelines would weigh in at between 8 and 10%, the new guidelines at between 8 and 12%, full WHO guidelines at between 10 and 15%. If we have the reduced cost, so the task shifting and the reference list, then it would be between 5 and 7%, 5 and 8, and 7 and 10% of the total health service budget. This was deemed affordable, which is why we now have the new guidelines. In conclusion, the increase in cost as a result of increased eligibility and better drugs is dwarfed by the increase in cost resulting from the growth in the population in need of ART, regardless of eligibility. So that's just to repeat that thing. We will see that growth, but not because we've made decisions about increasing eligibility or giving people better drugs. So in other words, HIV prevalence will continue to be a stronger driver of treatment costs than eligibility thresholds or drug choices. And our model indicates that the projected increases in treatment costs under both new guidelines would be offset by the introduction of new drug purchasing mechanisms and task shifting. Not only offset, but we're actually saving money. So with a new drug purchasing mechanism and task shifting, the total cost of the ART program under the new guidelines would be 25% less than under the old guidelines, while reaching 15% more patients. And implementing the full WHO guidelines would be 16% cheaper than continuing the old guidelines, while reaching 24% more patients. Okay. As we all know, and this is not going to be any news for anyone, but just to round it off, it's not very often that as a health economist you get to work on a program that then gets implemented. So just bear with me for a moment. Also because this, I think, in Vienna caused a lot more of a stir. The implementation of new South African guidelines and the commitment to treating so many more people out of domestic resources. So I really want to share that with you again. In April 2010, as you know, the new South African national ART guidelines were implemented, recommending the change that we modeled in the new guideline scenario. Task shifting has been agreed on, and new reference list mechanisms has been issued. So this is gazetted now. There's still discussion, but it is gazetted for the 2010 tender. And in February 2010, the national ART budget was increased by 96%, so almost doubled. This is the first time this has happened, providing care for up to 2.3 million patients by the end of 2012-13, and that is what we modeled would be needed if you have 80% coverage. And in order to increase coverage, and very much as a kind of follow-up from this increase in the funding for ART, the HCT campaign was started in April this year, aiming at testing basically a third of the population. There's a couple of next steps that are still outstanding for us, the model and also the program. We need to include the reduced NHLS cost. There's been reductions negotiating on CD4 cell counts, viral loads, and I hear also on the ALT. And we'll put that in, but it's not going to shave off much of the total cost. I already know it. It's going to be somewhere 5 to 7% just from my knowing what drives the cost there. We will need to, at the end of this year, start updating the coverage of the interventions that we modeled. So the early pediatric treatment, we assume at the end of the year we'll have reached 55% coverage of all babies, which is obviously highly enthusiastic and optimistic, which is what you want to do in budgeting. You don't want to under budget, but we will have to update that. Also, the initiation of TDF and the backup instead. Just by a show of hands, who in their own clinics has been starting patients on tenofovir since April? Can I see them? Okay, that's good. So just as a small survey, just to get an idea, but we will have to have a mechanism of finding out how much of that implementation is really happening, because otherwise we keep over budgeting. We need to eventually include inpatient costs just to see if it makes a difference. This one is actually central. The provinces need to improve their budgeting and expenditure tracking systems especially, because right now we keep submitting adjustment budgets because provinces haven't asked for enough money in the first place. I want to end with a quote from Jacob Zuma. The amount of resources dedicated to prevention, treatment, and care has increased with each successive year, but it is not enough. Much more needs to be done. We know that the situation is serious. We have seen the statistics. We know that the average life expectancy of South Africans has been falling and that South Africans are dying at a young age. These facts are undeniable. We should not be tempted to downplay the statistics on impact or to deny the reality that we face. At the same time, the epidemic is not about statistics. It's about people, about families and communities. Fellow South Africans, at another moment in our history, in another context, the liberation movement observed that the time comes in the life of any nation when there remain only two choices: submit or fight. That time has now come in our struggle to overcome AIDS. Let us declare now, as we declared then, that we shall not submit. So I finish off by thanking all these people that's here for you, the heroes. Some of which are here with us today. If lots of these people hadn't put in a lot of extra hours to get this work done, basically we had the first results within 2 months of a very complex model, we wouldn't have been able to do it. USAID South Africa fully funds my time on this, and I'm extremely grateful for their flexibility in doing so. The NDOH costing task team was incremental in giving instruction, but also then saying exactly what they wanted, and Jürgen Pille especially, and his rapport with the with the Minister of Health helped a lot in getting this through. Lots of other people contributed data, especially also the staff at the clinic. Thank you very much.